Once again, distinguished ladies and gentlemen, you are all welcome. HTA is a multidisciplinary process that uses explicit methods to determine the value of health technology at different points
Recording in progress.
Lifestyle or life cycle. The purpose of HTA is to inform decision making in order to promote an equitable, efficient, and high quality health system. It is in line with the above that HTA must follow a robust, transparent process with good governance to ensure that it delivers the desired benefit for the health system. It is in pursuance of this that we have gathered here this morning. It is on this ground that I welcome Dr. Mrs. Joycelyn Aziz, Director of Pharmacy, Ministry of Health, and co-chair to the HTA Technical Working Group. Let's welcome her with a round of applause.
I think it's becoming like a family, this whole HTA thing. And so before I welcome you, I would just like to give you a brief. We attempted to do it, but I would like to give you a brief about why we are here and then the welcome will come. So the rep from WHO country office, reps of all our donor partners, particularly PATH, UNDP, WHO. Indeed, there are so many. There's NICE, which is the UK National Health and Care Excellence. There's HTA, that's the Thailand Health Intervention Technology Project. We have several collaborators. Our regional health directors, and I must say I'm so glad to see so many of you here present. My fellow colleagues, all of you here gathered, both in-house and online, a very good morning to you. We are gathered here to celebrate yet another milestone, which milestone is to launch the process guidelines of our health technology assessment project. For those of you who don't know what this project is, it's simply a project that helps us to use documentary evidence, to use several tools, etc., to choose among others, a particular health technology or a device to address a particular health condition. And as the presentations go on, you understand more. But I must say this journey has been a very interesting one. I think the Ghana Health Technology Assessment Project is a very peculiar one. It started very informally, way back in 2012. And here I give credit to former Director of Technical Coordination, who is here with us. She'll be introduced properly. I don't want to print anything. Who played a key role to start this whole process of HTA, which is was in its nascent stages. It's going through. It's still then. I can say that it's gone past the milestone of a toddler, and is on its way to become a teenager. All I'm saying is that it's been quite an interesting journey. In fact, our health technology assessment started on an informal note. In 2012, we actually conducted an HTA on hypertension, and that led to the use of some antihypertensives that were even co-opted into our standard treatment guidelines. Moving on, in 2019, the structures were formally inaugurated, in which is the steering committee chaired by the Honorable Minister himself, a technical working group, most of whom are here in present, and I see Dr. Daniel Ankra, I see Ruby, I see William from NHI, several of them, and lots of them are also online. So we have the steering committee, we have the technical working group, and the secretariat, which is housed under my directorate, the pharmacy directorate of the Ministry of Health. And we are working very closely with the Director of Pharmaceutical Services, Ghana Health Service. So this process, as I explained, is just to help us to ensure that we have a robust system that will collaborate with all partners, relevant partners, to ensure that we are able to go through a robust procedure so that we'll be able to choose amongst others a particular intervention that would not only give us value for money, but also improve upon our health outcomes. So why are we here today? We started by development of a strategy which we inaugurated in 2020. Moving on, we have developed process guidelines that will sort of help us to operationalize the implementation of the strategy. There are other milestones, but our gathering here this morning is to launch the process guidelines. There will be a few presentations that will give you an in-depth knowledge of what the strategy entails and how we intend to implement it through the document that we are about to launch today, which is the process guidelines. So without saying too much, this is a brief background to our HTA story, and the reason for being here is to launch this document. There are other milestones, and I'm sure when those times, when we get to those milestones, now that we formed what I call an HTA family, I know that just as you've come in your numbers, when it's time again to launch another of such initiatives, you will be here to help us do that. So on this note, I say a warm welcome to you, and please try and get involved, particularly our directors of health services. I hope this is not the first time you are hearing about HTA, and if this is the first time, it's fine. We are happy to welcome you aboard. We are happy to work with you to ensure that this very important project is implemented in a way that will not just be a talk shop, but would help us to be able to implement our universal health coverage. In fact, this health technology assessment is actually a cost containment tool. It's supposed to be used to help us to select what kind of medications, what kind of devices we would use as healthcare workers. And so, more importantly, it is to help the National Health Insurance. Why is it supposed to help the National Health Insurance? Based on the output of health technology assessments that will be conducted or that have been conducted. In fact, we've done quite a few. We've done HTA on hypertension, like I said. We've done one on Becky's lymphoma. We have done one on management of pneumonia in children and a few others. So the reason why I'm saying that is a cost containment tool is that the evidence that is generated from each HTA that is conducted would help us to decide on which conditions would include in our essential health services package, which medicines would include in our standard treatment guidelines and our essential medicines list, as well as form the basis on which the health insurance would decide on which medications and other devices they would include in their benefit package. So if this is not sitting well or you are not understanding, don't worry. As the presentations go on, you get an in-depth understanding of what this whole thing is about. And like I said, I'm using this opportunity to extend a hand of, an invitation to invite you all to come on board. The secretariat is there. It's housed within the pharmacy directorate of the Ministry of Health head office. We are always available to explain the issues to you and also show you how you can collaborate with us to ensure that this very laudable project is implemented in a manner that will give us the best value for money. And remember, I said, ultimately, we are not just reducing costs, but we want to, more importantly, improve health outcomes. So on this note, I say a warm welcome and sit back, enjoy, ask as many questions as you can. Welcome to the HTA family. Thank you very much.
At this point, our chairperson will surely give us her opening remarks.
I am very happy indeed that I could be asked to chair this. I am indeed very pleased also that within a couple of less than 2 years, we launched the strategy for HTA in Ghana. I must say that HTA, as you know it, is just a tool for decision making. And we must have that at the back of your mind. And that tool must be well developed and well processed in such a manner that nobody can argue that this is a politically oriented decision. And this is important for the industry, and it's also important for technical officers. And it's important for politicians because if, for instance, you are being asked by your president, why do you have to take this? Said, oh, it is based on the evidence. But when the evidence is not there, you try to struggle to get the evidence to support your argument. And so I am indeed very pleased that I should witness this, and I must congratulate the directorate and the secretariat for keeping the banner up The reason is that HTA without uptake is just academic endeavor. And it is important that this process document that are going to be launched today provides step-by-step ways of when the work is done, when the process are completed, and how the uptake should happen. And I think that this is important for all of us. Ghana will no longer be the same once we begin to uptake or use the HTA decisions to guide our policy decision makings. I thank you, especially for regional directors who made time to be here. HTA must start from the bottom. It doesn't start from the top. And that is why your presence here is so important, because you are going to carry the process forward and ensure. And I'm sure if you recall, WHO supported ministry to train some people in health economics. And I trust that those are the capacity building things that have been put in place to ensure that there is a crop of people who will carry the processes forward. It can be only better. I thank you for the opportunity to chair, and I accept it, and I work with you.
I am here today speaking on behalf of the Access and Delivery Partnership. And for those of you who aren't familiar with the Access and Delivery Partnership, it is a Government of Japan funded partnership led by UNDP and contains WHO, TDR, which is the Special Unit for Training and Research in Tropical Disease, and my organization, PATH. And I'd specifically like to acknowledge our UNDP representative from Ghana, Ms. Belinda Amwankwa. Thank you. Together, ADP collaborates with 9 countries in West Africa, East Africa, South and Southeast Asia to ensure access to new health technologies, specifically health technologies for malaria, tuberculosis, and neglected tropical disease. Over the last 2 years, in the midst of COVID and despite COVID, it has been a huge privilege to work with the Secretariat and the Technical Working Group to establish the HTA committee and create these guidelines. And the one word that I would like to share with you on this is collaboration. As Dr. Azari said, this wouldn't have been possible without the leadership of Dr. Gonzalo Durot, her vision, championing her long-term vision for bringing us to here. And the team at the MOH, led by Dr. Joycelyn Aziz, you have had such clarity of vision about how to get us where we are, and thank you for that. I did a rough count as we were introducing ourselves, and roughly I saw 17 different Ghanaian agencies or directorates or companies or schools that are here today. I think there's 6 representatives of global partners, and I think I saw 3 other countries that are online. And again, collaboration. This is what has brought us to where we are. I'm not going to go into details on what the guidelines are. I will leave that to the experts. But I would like to share a message to this team, or make a request to this team, which is please be vocal. Please share your lessons learned, your challenges, your accomplishments, because other countries need to learn from Ghana. The global health community needs to learn from Ghana, because you really are leading the way in the region. And yeah, please. And so in closing, ADP looks forward to continuing collaboration with the people in this room and helping to disseminate your lessons learned beyond the borders of Ghana, and so we can all learn together. So thank you very much.
The World Health Organization is pleased to be here this morning to participate in the launch of the process guidelines for HTA in Ghana. And we would like to commend the Ministry of Health for the successful development of the guideline. HTA as many of us know, is a multidisciplinary process that aims to determine the value of health technology and to inform guidance on how these technologies can be used in health systems. It is a transparent and accountable process used by decision makers and other stakeholders for decision making, and has been a catalyst for country health systems that would prioritize value for money in deploying interventions. In fact, we describe it as a bridge that connects the world of research to that of policy making. Madam Chair, Ghana has demonstrated commitment to apply HTA to policy prioritization, benefits package design, including clinical services and reimbursements, optimization of our essential health services, selection, as well as selection and pricing of health technologies. The application of health technology assessment in Ghana is expected to contribute significantly to Ghana's universal health coverage agenda, where all people living in Ghana can access quality essential health services without having to suffer financial hardship to pay for health care. Ladies and gentlemen, in order for HTA to deliver its value, it must follow a systematic and transparent process with good governance and scientific rigor to ensure optimal outcomes from the application of HTA within the health system. The optimal application of HTA with health systems, we know, has the potential to accelerate efforts towards UHC, as has been the case in some country settings. We take this opportunity to congratulate Ghana for its commitment to use HTA as a prioritization tool to help ensure optimal allocation of resources for health, as well as help create fiscal space to promote equitable, efficient, and high-quality systems. Madam Chair, the World Health Organization is happy to be part of the ongoing process of institutionalization of HTA in Ghana and will continue to work with partners to support the strengthening of HTA in Ghana. Finally, we congratulate the government of Ghana for this step and will also continue to support government priority technical areas to accelerate the country's efforts in attaining universal health coverage. Thank you very much.
But I just want to highlight to you all what an achievement this is. The journey that Ghana is making in its HTA institutionalization is non-stop. It's progressing at pace. It may not seem like that for others, but it's managed to achieve a lot. And all HTA systems need to create standardized processes. And we've heard from previous speakers why that's important. It helps guide HTA and provide clarity and transparency to all stakeholders on the various steps. And developing a process guide shows intent to be credible, to be legitimate and serious. And it's clear to me that this is what this process guide aims to do. It is important, as colleagues from HITAP have said, that this is a learning document. You test it, you apply it, and you adjust it. So there's got to be flexibility here. So learning is crucial, but nevertheless, this provides a clear statement of intent about how the process should operate in Ghana. And as we were also reminded by Dr. Aziz, HTA here is a tool to support priority setting for UHC and benefit package design with the ultimate goal of improving health outcomes. We're not doing HTA as an end in itself. It's there to ultimately improve health. And an important part of that is setting out clearly how you're going to use your HTA. How is it going to not just be an academic endeavor, and setting out process guidelines are part of that. I'd also like to strongly endorse Betsy's comment that I believe what's being done here should be shared with the global community. There's lots of people here that can learn from the wonderful experience from Ghana, and there's definitely a need to disseminate the lessons learned. So thank you again for allowing me to speak on behalf of the London School of Hygiene and the International Decision Support Initiative, which has had the privilege of being able to support HTA development in Ghana for many years now, including the important initial engagement around the hypertension HTA that was mentioned earlier. I'm very pleased on behalf of the group of people that I represent, and indeed all the partners engaged in supporting HTA institutionalization, to be here speaking to you and pay homage to what you've achieved. So many thanks.
Health technology refers to a test, device, medicine, vaccine, procedure, program, or system used to promote health. In simple terms, they are tools that are used to provide health services to all persons as they go through the health service delivery system. Access to these health technologies is complex and requires consistent, accurate, effective decisions on matters relating to the health system to ensure that the health of the population is secured. HTA is a multiplicational process that uses explicit methods to determine the value of health technology at different points in its life cycle. This cycle ranges from research and development through approvals, certification, and market access to application to users, patients, etc., as well as monitoring of their effect on patients and the population at large. Each phase of the health technology assessment process requires investment and funding by government and the health system in the area of research and tested efficacy for improved health outcomes. This calls for strategic and informed decision making regarding adaptation and use of health technologies. This is the need. It is this need for evidence that HTA seeks to bridge. Madam Chairperson, ladies and gentlemen, HTA is an established tool which can contribute to universal health UAC through the provision of evidence to optimize decision making. In our current economic difficulties, worsened by the COVID-19 pandemic, policymakers are challenged with difficult decisions about cost-effective interventions for sustainable access to health care. Healthcare managers are also compelled to make decisions regarding which services should be prioritized, which populations should be targeted, as well as how much resources should be allocated. This is not an easy decision because there would always be an opportunity cost with an option to choose over the other. There are also concerns about equity in the allocation of scarce health resources to various sections of the population. The above dilemma is one of the critical puzzles which must be resolved in order to move the health system in our context as a low middle income nation towards achieving UAC. Such difficult decisions with respect to prioritization of services, resource allocation, optimization of coverage and cost can be supported by HTA. Madam Chair, the main purpose of conducting HTA is to inform policy. Decision making within the policy process encompasses application of organized knowledge and skills to decisions on medicines, medical devices, vaccines, procedures, systems developed to solve health problems and improve quality of life. It is therefore paramount that policy decisions at all levels of the health system are based on evidence, including evidence obtained from HTA. This multidisciplinary process analyzes various dimensions with respect to health technologies, including safety, effectiveness, cost effectiveness, equity, and even legal dimensions, among others. This is a comprehensive approach and is valuable for effective decision making in the health system. Already, HTA in Ghana has been successfully deployed in the review of guidelines for hypertension, diabetes mellitus, Becker's lymphoma, and COVID-19 treatment protocols, which did not only improve practice, but also provided cost-effectiveness evidence for inclusion of some of respective medicines into the NHIS medicines list. This is commendable and needs to be strengthened to cover other aspects in the health delivery system. Madam Chair, as we launch this HTA process guideline today, it is my firm belief that this will provide us with opportunity to establish a trusted and consistent process to guide how HTAs would be done and used in Ghana. This is a great step towards HTA generalization in that when the process is flawed, the outcome could be questionable. On this note, as I bring my statement to a conclusion, I will say that Ghana Health Service values the role of evidence-based decisions in defining health services to be provided to the population and remains committed to onboarding the outputs of this robust and transparent process towards achieving UAC for our population. Thank you.
The whole idea of HTA began on an informal note, spearheaded by Madam Dr. Jansa Lutrot, who is the chair for this program today. So among her many interactions, she came into contact with this whole HTA agenda, which was being pursued by other countries. And then she started these informal discussions, which continued into the country. So as far back as 2010, between 2010 to 2013, there was a need to establish some form of efficiency within the health system. So this whole discussion began to gather some traction. And then WHO came on board quickly because it was a process that was already in place in other countries like the UK and the other developed countries. So the WHO came on board, and this informed our medicines selection. So in the process, after applying some level of HTA to the selection of medicines, it informed the delisting of some medicines from our national essential medicines list. So we delisted rosiglitazone and then also included chlorhexidine in the medicines list. From between 2014 to 2017, again, a number of things took place. So there was still the need for us to establish continuous evidence to inform decision making. And so there was a study tour to the UK, NICE, to look at their processes and see how we can actually bring them home. And then in the course of the interactions with NICE, we were looking at what are the lower hanging fruits that we can start with, which will bring immediate value to our health system. And of course, at the time, because she was the director of pharmacy at the time, starting with the medicines was a bit straightforward for her. And so that's where it started from. So we have actually applied HTA to the medicine selection and then to other things regarding medicines in the country as we speak now. Then it also informed the development of the National Medicines Policy, that's the third edition, which was outlawed in 2017. Then again, we saw the need to try our hands. Together with our development partners, we saw the need to try our hands on hypertension. Why hypertension? It happens to be one of the highest cost drivers on the National Health Insurance Authority, reimbursement list. So we, together with our partners, there was a successful HTA on hypertension. And again, it informed the then medicines, the standard treatment guidelines, which was outlawed in 2017, and then which eventually also translated into what we have on the NHIS medicines list. We continued with capacity building at the time, way back in 2017, through the use of Webness. After the visit to NICE, we're using Webness also to build capacity in-house. And then there was the need for us to officially and formally institutionalize HTA within the Ghana health delivery system in order to promote efficiency. So the objective at the time were, one, to establish a country structure for HTA officially, develop in-house capacity or in-house country capacity for HTA, strengthen the science and practice of HTA, and also to optimize resource allocation and then to contain costs of healthcare delivery. So those were the key blocks. And then we're going to do these through the use of evidence, which HTA seeks to achieve. So we were looking at, one, policy prioritization as the objective, selection of technologies, benefit package design and reimbursement onto the National Health Insurance Scheme, determine the essential health services package, and then procurement and pricing of pharmaceuticals and other health technologies. So these were the objectives that we set for ourselves as far back as 2017. And these objectives led the Minister of Health bought into these objectives. He saw the need for us to actually institutionalize HTA in the country. We had demonstrated after the hypertension exercise, and after many interactions with him, we had demonstrated that HTA was going to be of a benefit to the country, especially our health system. And so the minister in 2019 inaugurated the HTA and formally institutionalized it as a process within our health system. So there was the steering committee, the technical working group, and then the HTA secretariat, which was inaugurated on that day. And when we look at the picture, we see the minister seated there. We see our chairperson also seated there, and many other dignitaries who were there at the launch or at the inauguration of the committee. So this is how our governance structure looks like. So we have the HTA steering committee, which sits at the very top, that takes decision. And the committee is made up of representatives from the various agencies and agencies within the ministry and outside the ministry. So we have people from academia also on the committee, and then we also have partners from all over the Ministry of Health agencies also on the committee. Then we have the secretariat, which sits in the middle to coordinate activities of HTA. And then and situated at the Ministry of Health currently under the Directorate of Pharmacy. Then we have the technical working group, which is also made up of experts from various fields. Again, we have quite a number of experts from academia, University of Ghana, KNUST. Professor Bafor is here. He has been a key member. And then Professor Novinho has also been a key member from University of Ghana, has also been a key member of the technical working group. And then we have representatives from the Food and Drugs and many other agencies of the ministry forming the technical, with the requisite expertise, forming the technical working group. Then the secretariat, of course, is the one that interacts with all these structures. So we also have our partners and networks across the country, abroad, and then also we interact with both public and private sector stakeholders. Of course, HTA cannot sit well if we don't involve the private sector in the things that we do, because the decision and what the decisions that will come out or the outcomes of HTA may affect the private sector as well. So they are also well represented within the HTA structures that we have built. So the actual work began, and once the structures were put in place by the minister, we started work. And this led to the launching of the HTA strategy for Ghana. The strategy basically was to guide how we were going to do our things within the country going forward. So now we have moved from the informal process or system that started to a more institutionalized and a formal process, which we see now. So on the 3rd of August 2021, Ghana launched the HTA strategy, which was intended to guide our processes. Now, the strategy has 9 strategic areas, which starts from governance to topic selection or technical work. The guidelines and manuals, one of the guidelines is what we have just developed and we are about to share with you. It talks about the resourcing and tooling, resource mobilization, implementation and follow-through activities. Of course, when you are done with the HTA, it doesn't stop there. You have to also follow through with implementation and then actions to be taken forward. It also talks about communication and dissemination of HTA work. So we are so happy to have all of you here in this room. It means that our communication strategy is gradually working. The fact that we are able to bring all of us here and then those online to be in this lunch is a manifestation of the work that the system is doing at the moment. And then, of course, collaboration and partnership. We have all seen the number of our partners who have spoken to us just before I came in. And then, of course, to build in-house capacity for HTA in Ghana. So these 9 pillars form the strategy that was launched on the 3rd of August. Now, after launching the strategy, we started implementation. So we have 50 strategic actions within the strategy that we needed to implement. As we speak, work is ongoing or completed on 31 out of the 50. And that represents about 62%. And work is yet to commence on 19 out of the 50, representing 38%. So let's go to what we have done so far. We did an HTA again on Becket lymphoma. That was just around the time that there was a lot of advocacy to include childhood cancers on the NHIS. So we did an HTA around Becket lymphoma. We wanted to establish whether it was cost effective for us to put these cancers on the NHIS benefit package. We did the work on it, and then it reaffirmed that it will be cost effective, it will benefit the country, it will benefit the population if we should include HTA on our benefit package. Let me say that in the conduct of HTA, it looks at all dimensions. So apart from the cost effectiveness of the intervention, HTA looks at the political aspect. HTA looks at the social aspect. HTA looks at the ethical aspect. So it looks at all dimensions before you can say, yes, you have completed an HTA process. You look at the scientific aspect, you look at the cost aspect, you look at the politics around it, the condition or the intervention that you are doing the HTA on, you look at the politics around it, or even the politics within the country, whether it is rife for us to do this or not to do that. Look at, is it ethical to do this or not to do that? So all these dimensions or perspectives come into decision making when you use it, and it is the reason why HTA is bridging the link between academia and policy making, because at that point you look at all dimensions before you say, okay, it is good to proceed, or no, we have to hold on, or no, we have to negotiate before we can implement. So after HTA on Becket lymphoma, it reinforced the fact that we needed to include these 4 childhood cancers on the NHIS. And the launch of the inclusion of the 4 childhood cancers was done by the First Lady of Ghana, Mrs. Rebecca Akufo-Addo. which was also well attended by most of our partners. Following the launch, we developed a 5-year implementation follow-through. We needed to follow what has happened after we launched the HTA on Beckett and Informa. So we were looking at the governance around it, the quality of care issues, awareness creation, financial risk protection, and then the implementation impact or impact assessment following. So this is something that is ongoing. It's a 5-year implementation project that we are doing as I speak. And then I'm sure when at the end of the 5 years, we'll come back and share our findings with you like this, on the, in a platform like this. Another thing we are working on is to assess the legal space within which HTA is situated. Of course, for HTA to make the impact it is supposed to make, we need to build some laws around it, or it needs to be situated very well within the laws of Ghana and then within the laws that governs healthcare in Ghana. So we are also looking at establishing the structures and the legal framework that will govern HTA activities in Ghana. Again, in 2020, when COVID struck everyone, the HTA was contacted to do costing on the COVID-19. At the time, Ghana was at a decision point. We needed to go for vaccines, but then we needed to do costing and other background work to be sure that the decision to go in was either good or not. So the committee was contacted. We pulled a lot of experts together, and we did costing on COVID-19. What we noticed out of the costing we did was that 80% of the cost of administering the vaccine, the COVID vaccine, was actually the cost of the vaccine. So we had the cost of the vaccine and other things that goes into to finally administer the vaccine. And we realized that 80% of the cost was actually on the cost of the vaccine. And so it means that if the government was going in, you need to negotiate well on the cost, because that was the highest impact on the whole project. So we did this, and we got a lot of applause from the government for doing that work. Then we also developed, or we are developing, the reference case, which is still ongoing among the number of things we are doing. We are hoping that within the first quarter of 2023, we are going to launch the reference case for HTA. Again, diabetes happens to be one of the highest cost drivers, again, on the National Health Insurance Scheme. And so at the launch of at the inauguration of the steering committee and the other structures, the minister actually commissioned us to do an HTA on diabetes. And so we have also started the processes around diabetes. We've done the scoping, we've done stakeholder engagement, and then we've done policy review of management of diabetes within the country. We are looking at, our focus now is on the insulins and the gliptins. So at the end of the day, when we are done, like I said, communication is one of the key strategies within HTA. So when we are done with the diabetes HTA, again, we will communicate the findings to everyone, and then it will inform the standard treatment guideline and then the NHIS reimbursement list. We are also, currently Ghana, we don't have figures for our QALYs and DALYs and all those utility figures. We don't have them. So one of the things the HTA is working on now is to develop QALYs and DALYs for Ghana, so that these becomes standards within which we can actually compare, within which we can say we are making progress in a particular area in terms of an intervention, or we are not. So this is something that we are doing. These are international standards that we will collaborate with our partners to develop our own. So as it stands now, when we do our work, we make reference to other countries in order for us to arrive at a decision. But we need, our context is different. And so we need to develop our own indicators so that we can use these as our reference whenever we are doing any analysis on our health indicators. We have also done a lot of capacity building activities, so many of them, so many capacity. Between 2017 and now, a lot of capacity building activities have taken place with the support of our development partners. So many. In 2021, for instance, the WHO supported the ministry to grant scholarship to about 20 staff within the Ghana Health Service and within the ministry, let me put it that way, which includes all the agencies, who went to the University of Ghana to study health economics. Do we have some of them here? Yes. So all the hands we see here, they got the opportunity to go for further studies in health economics in order for them to come and support the work of HTA. So through HTA, we are actually developing in-house capacity in areas that hitherto we didn't have that capacity. Again, we have partners who are also supporting our work. So for instance, NIPH has designated 2 PhD candidates to support the work of HTA in Ghana. And then also there are countless areas of capacity building in terms of, now that we have done the masters, in fact there are PhD opportunities as well for those who want to proceed with PhD in HTA. And let me say at this point that KNUST, University of Ghana, and then UHAS have all been our collaborators along the path. And we are hoping that it will continue and even get better. So still on capacity building, there was capacity building activity on modeling, mathematical modeling of infectious diseases when we wanted to do an HTA on pneumonia in children. So they had to build capacity around that area. There's also capacity building ongoing around implementation research. There's capacity building ongoing around supply chain adaptation for new technologies. And then so many other capacity building areas that are ongoing. And it is our hope that within the shortest time, Ghana will have enough experts in the area of health economics and HTA for us to be able to actually be on top of what we are doing. Recently, as it was mentioned through the presentation, there was also a study tour between Ghana and HITAP. HITAP is situated in Thailand. They are the HTA body in Thailand. So there was a study tour from Ghana to Thailand, HITAP. And if you look at the back, you can see me there. And then you can also see Brian. Madam Aziz is also there. And then a host of others who have even spoken to us on the screen earlier on, some of the partners who spoke to us. So there was this study tour to deepen our understanding of their processes, because just as we were about to launch our processes, we want to clearly understand, because they have been in existence for almost 20 years. So we want to clearly understand how, and then their context is a bit close to us because we are all within the middle income kind of bracket. So we needed a setting where the context is a bit close to Ghana, and then we can actually learn from what they have done. So we were there for almost 5 days, and they took us through they were very transparent with us. They took us through all their processes, and that informed the final version of what we are going to actually launch today. And what are some of the upcoming work on HTA? So we are looking at the reimbursement list on the NHIS, that's anemia and malaria. We are going to look at that. We are going to look at maternal health services, infectious diseases and antimicrobial resistance, management of NCDs, and then system level interventions affecting NHIS. So in all this, cost saving is at the back of our mind. The decisions we take should translate into some form of cost savings, which obviously is the NHIS that purchases health services. And so once it translates into that, then we can see some cost savings within the NHIA. We are also looking at the essential health services package. This is a huge document that Ghana has developed. And we have gotten to the point where we can actually, we are looking at using HTA to make sure that the interventions that have been outlined within the essential health benefit package are indeed interventions that we can pay for and will be cost effective. So not too long ago, there was a gap analysis. The NHIA was tasked to look at the gaps. What are we paying for currently and what are we not paying for as per the document? And we have done those gap analysis. The next thing we are going to do is to also do costing on the services that have been approved, and then look at which ones are cost effective, and then do an HTA to be able to be sure and certain in our minds that indeed whatever is in the package we can deliver. So I think I will bring my long history to date. So to date, this is what we have done. And then I'll give the room to Brian to come and continue with the launch of the process guidelines. Thank you.
Indeed, from the earlier presentations, we get the sense that this whole thing didn't just start immediately, didn't start now. It has been warming up for some time now. And this process that we are going to present actually borrows from what we know and are comfortable with in our space, in our system as Ghana. And from 1988 all the way to date, there's a process that has been sustained in Ghana through Ghanaian experts who have contributed to development of treatment guidelines, updating medicines lists. And this process has to do with the use of evidence to inform decisions, but then it's specific in terms of decisions around treatments and care and which health interventions to use in what disease, looking at the best evidence available. So it's a process that we could learn from, because at least we know from 1988 till now, if a process is ongoing and has not failed, then it will contain lessons for sustainability. So we learned from this, and I've shown you some of the images from previous work that has been done in this area. Next slide. Next one. And indeed, during COVID, you could see that there was a lot of restriction on movement. So even if you wanted to import expertise, you were constrained. They could only support remotely. And we still had to leverage this process in such constraints to support our own country. Okay. So we are using expertise all right, but you can tell that there's also a strong emphasis on building local capacity as well, working with all the capacities that exist. And the process that was used to develop all those guidelines from 1988 to date is what is illustrated here. I know it's dense and it's complex. I'll summarize it in just a few statements. So you have a minister who inaugurates a process. You have technical experts meeting to review things. They are subject to cross-disciplinary review. So you have, let's say, a cardiologist look at some other aspects of endocrinology and they peer review each other's work. It is subject to wider consultations for even non-clinicians, civil society to also make inputs, because we may not understand your drug receptors, but then we know how we feel when we take a drug. So everybody is given a voice at that point. Then they do further collaborations, and then decisions are taken, and then that process comes up. So it uses evidence, and then it also consults with wider stakeholders to arrive at that. This is what we have been doing in the past for treatment guidelines. Now we had to introduce HTA. So then HTA makes an input to this process. Next slide. Having said that, we also use global best practice. And one of the global best practices that is informing our treatment guideline is what is called the evidence deliberative processes. So you needed to have some governance structures in terms of an advisory committee. You needed some explicit criteria. Then you needed steps for every technology. So step A, B, C are things that you set and then you pause. But then when it comes to every technology assessment, you would scope, assess, and appraise, after which you do communication and then monitoring and evaluation. So this is a generic framework for methods or processes that will use evidence to make decisions. And it's published, and we borrowed from this as well. So when you superimpose this on the Ghana process, then we saw what could be a possible process for HTA. Next slide. And that is what you have there. So it looks like a linear process, but then it has inputs from other auxiliary steps. But then some of the steps are also reversible, that you can go back and you can move forward. Okay, so I'll take all these steps one by one, and then we can have some sense of what we will do when we are producing HTAs in this country. Next slide. So the first one is topic nomination. So HTA is an expensive process. I mean, if you look at the evidence that should go into an HTA, it's an expensive thing. If you don't have data that already exists, you have to collect some primary data to support it, and all that comes at a cost. So really, if you don't have to do an HTA, then don't do it. But then if you have to, then you need to go through the rigorous process of doing it. Number two, this is a decision science. And for decision sciences, the outcomes can sometimes be high in terms of stakeholder interest. And because of that, you need to outlay a process that everybody understands and everybody can describe, so that the approach to the evidence that informs a decision is something that we can all accept. And when we all accept the approach, then it means that the outcomes too can be acceptable. Okay, so it's one step that is very critical in terms of which topics should we do HTA on. And for this one, what the process guideline is saying is this. So there will be an instance where the secretariat will throw out a call for all stakeholders, private, public, across, all the broad interests, to nominate topics that will be conducted, that will pass through HTA. All those topics will be compiled. Now, that is the regular calls that will be made. Now, there's also some room for ad hoc nomination, because it's a health system and it's a complex system. So sometimes the need for certain decisions would come when we have not even planned for it. And HTA should be able to support us in that way too. So there's room for topics to be nominated ad hoc, not as part of the regular calls that will be made. Now, that is compiled by the secretariat and then passed on to the technical working group for the next steps to be done. Next slide. So the next step is called topic selection. In Ghana or in other settings, when it said topic selection, it actually means topic selection and approval. So the technical working group receives all the structured list of topics that has come through, whether by nomination or by response to a call. And then they apply criteria to rank the topics and select the topmost important ones that should go through this process. There was a question on the time period for all of this. So in the presentation, you realize that we've allocated times to each of the steps. And then we've also indicated who is doing what. So in step 2, TWG in the blue is doing the topic selection, that is applying the criteria to, let's say if we had 2,000 topics. At this point, 2,000 topics is not practical at this point. So we'd have to skim down to the most important. And of course, if you have done an open call, people will bring a lot of topics and it will cut across a lot of issues. So the criteria will be applied to narrow down the number of topics. And then that criteria is the outcome of applying the criteria. The narrowed list is passed on to the steering committee for them to review and commission HTAs on those topics. So maybe we'll have a look at the next slide, which will talk about what criteria is applied to sift the large number of topics to the clean, straight to the point ones that's worth investing into by way of HTA. So we are looking for things or topics that have a potential for cost effectiveness. Okay, so there are areas where you invest, you get the most value for your bucks. If we are to do an HTA in an area, we want to do HTA on topics that have potential positive cost effectiveness potential, like high cost effectiveness potential. That's one criteria. We also want to do topics that have a high number of potential users or beneficiaries. So the numbers involved when it comes to the particular issue of concern. Then we also want to look at topics that have much more benefit compared to existing technologies. So if there's a potential technology that is more beneficial, more effective, more impactful compared to an existing one, it's also a criteria that is important. If there is, in fact, if all of these are not scoring and the topic is actually purely on an issue of equity, then it's also important. So on the level of equity, a topic will pass this criteria. Then we talk about potential budget impact. I mean, some issues may be cost effective or even not cost effective, but then their budget impact may be significant. So that one is also important. Then we've added a little bit to the budget impact, and here we are talking about the household economic impact, as in the potential for catastrophic expenditure when it comes to the individual spend with respect to healthcare. And that leads us directly into our discussions on universal health coverage, because removing catastrophic expenditure is critical when it comes to driving our health system towards UHC. So this is the criteria that we are using at the moment. But like as we've said, this criteria would evolve over time. But within the first 5 years of implementing HTA, within our first 5-year strategy, the technical committee plus all the stakeholders consulted and all felt that this would be a starting point, and that as we progress, we could drop some criteria, introduce other ones, and all that. So it's a living document, but then we have to start from somewhere. Next slide. So after that criteria is applied, we'll have a lean list, a potential lean list of topics. And then we go to the next point where we begin to scope the topics. What it means is that we are going to define the specific populations that will be affected, the interventions that we'll be focusing on, as in specific interventions this time. The truth is that when you have topics nominated, sometimes they come as single sentences. Sometimes they come as ideas. Sometimes they come as paraphrase things. But then HTA is also a science. So you needed to, after that, structure in a scientific way or position the topic such that it can be answered in a scientific way. So that is done in the scoping. And then after the scoping, we also engage technical stakeholders to look at sources of data and any other technical considerations that should go into the analysis and all that. So this second stakeholder, at the topic nomination, there's a wide stakeholder consultation, but then at this point, we get a bit technical with a selection of stakeholders at this point, because we are looking at data inputs and we are looking at refining the questions, and we are looking at the kind of policy questions that are critical and all that at this point. Next slide. Then we come to the assessment. So the assessment, from the earlier presentation, we saw the structure of the HTA. So there's a steering committee, and then there's a technical working group. The technical working group has subgroups. So there's an analysis subgroup, there's an appraisal subgroup, and there are other subgroups for capacity building, communications, and then capacity building, and appeals, sorry. So this is one of the longest steps that we have in the whole sequence. And here we're saying that it could last between 12 to 52 weeks. It could last for up to 12 weeks in a rapid approach to HTA. So if you look at the timeline, they are always two, because we have a full HTA and then we have timelines for a rapid HTA as well. Because working in this space for some time, what we have realized is that when a policy decision has to be taken, there's always that kind of dilemma and trade-off between the technologists and the scientists producing solid, robust evidence, and then speed at which the decision has to be made. Okay, so for instance, we need to make decisions with respect to a public health emergency. But then that decision has to be also informed by some evidence. And there has always been that thing. So do we accelerate? And when you speed up, there could also be trade-offs for quality of evidence. And if you are not also able to generate evidence and submit in time, the decision makers are under pressure to take decisions. So it's always a constraint. But then that is why you can see that in this process, there's a full HTA and a rapid one, which is supposed to be generating outcomes faster. And we'll see the difference as we go along. So there are methods which would feed into the assessment. And in the area of methods, what we've done now is that we have a reference case which is draft, and I think it was alluded to earlier that coming first quarter next year, that would have been complete. So we have two things: the stepwise approach to follow to do HTA, as well as the considerations for the science and the methods that should go into the report. So those two things would help us to produce a lot of HTAs moving forward into 2023, because now we have those two legs, very important, established. Now, from TWG assessment, you can see that there is a TWG, and then there's also space for co-opted partner assessments. From lessons that we've learned from other HTA bodies, some of the topics that would go through HTA, especially when you have put in a call, can really be high in terms of the numbers and the number of analysis that has to be done. And frankly, if you look at even our current essential health service package, if you want to prioritize and approach that with an HTA approach, you realize that there's a huge number of analysis that has to be done. So in terms of that, you realize that then in trying to build systems for HTA, you need to build systems that can scale to be able to do high numbers when the need arises. So in order for that, there's a space for co-opted partner assessments. So for instance, the Secretariat is building some technical capacity, the TWG is building capacity. But then if, for instance, there are centers of excellence or centers of consortiums and entities that have capacity to produce the analysis, by doing a reference case, it means that if you subject that center to the HTA process, because so far as it's an HTA that informs decisions by everybody, then it means that the processes should apply. Okay, so it will be done under the TWG with technical supervision from the TWG. But then what we are saying here is that these partners, or there's room for partnerships even in the production of HTA in that level. So the report is produced, and then the TWG produces a summary of that report. So that this summarizes the assessment. It will come from these points that I mentioned, but then it has to be part of this process, because this is the process that informs our decisions around policy. Next slide. The next step is appraisal. So this is typically scientific quality assessment appraisal. And the appraisal subgroup will scrutinize the analysis that has been done and then try to condense the information and try to establish the quality of evidence and all that. And after that, the appraisal subgroup will then also classify that evidence and prepare briefing notes, because they have to reduce all the evidence and submit it to the next step, which is a steering committee responsible for decisions and deliberations around HTA. So that is the job at this point. We are thinking that 4 weeks should be enough for this. And if we are in a hurry, we'll do it in 1 week. Next slide. Now, 2 things come out of the appraisal, and this is very important. So there are dimensions that we assess for HTA. So there is safety, and we are talking about relative safety. Effectiveness, level of evidence for the effectiveness, cost and cost effectiveness and level of evidence, severity of disease, budget impact, equity. Now, this dimension would be an output from the appraisal. So at this point, you can realize that this doesn't look at numbers, it doesn't look at figures. But then they are telling you that in terms of effectiveness, this particular technology is more effective or is better than the comparator at least. Or it has comparable effectiveness with the comparator, or it's actually not effective. In other words, it's worse than the comparator. So that's an example. So this summarized information goes into the next step of deliberations by the steering committee. At this point, everybody has information on all the various dimensions of the technology that is being assessed. Now, the next slide. So this is a qualitative algorithm that will help in the deliberation process. The issue is this: if you present a summarized evidence on any technology from the previous slide and you give it to everybody, the approach to analyzing that particular evidence could be different. So then you needed to also guide the approach. And here what we are saying is that, first of all, first do no harm. So if the technology is not relatively safe, then it cannot be considered in terms of a recommendation. If it is effective, then it can be considered, but the next criteria will kick in terms of value for money, that is the cost effectiveness. If it has comparable cost effectiveness, at least it is safe, but then it is not more effective, but it is comparable. So that is also of interest. Then if it is not effective, we are also not interested in interventions that are not effective because it will be waste of resources. Then at least if it can pass for safety and effectiveness and cost effectiveness, then it's something that can be looked at. Then other parameters can be considered. So deliberations on severity and equity, affordability and feasibility would also be considered. The attempt that this is doing is just to structure the approach to using evidence, basically at the level of the steering committee. Is this 100% fail-proof? I don't think so. But then at least we'll start from somewhere, and if we have constraints, we'll document our lessons and update. So next slide. So that becomes the deliberation step. It's presented to the steering committee. They will use what I presented earlier to do their deliberations. Next slide. I think I've said this already, so we can move on. But another point that I think is worth mentioning in the previous presentation is that we are looking at roughly 3 different types of recommendations. So one, it could be that for this technology, recommend. Or it could also be that this technology recommend, but then change the conditions. Okay, and when it comes to the earlier discussions on pricing and price negotiations, there could be technologies that will say, okay, fine, we could recommend this technology subject to change of price. It doesn't mean that it's a price regulatory regime. It means that we are engaging and nibbling subtly at prices using evidence and allow market forces also to be at play. So that is one, recommend with a caveat. And then the other one is outright not recommended. Okay, so these forms of decisions are possible. Next one. Next one. Now, the output of the deliberations at the steering committee level, there's a structured format for that. So on the level of, and this helps with voting at the steering committee level. So on the level of, let's say, severity, a steering committee or the steering committee could vote yes, but then you cannot just vote yes. You need to provide justification. So that justification is required. Then on the level of equity, there could be a yes or no. And then that's just because you've been provided with the evidence, okay, and it's summarized in front of you. Then the affordability is also voted on and all that. Now, all put together, then there's a final recommendation considering all these dimensions that are normally analyzed in the HTA framework. And then a recommendation is taken. What it means is that if you wanted to trace systematically what or how the decision was arrived at, these will be available as documentary proof that is supporting the logical approach to arrive at that decision. That, and I know this is pretty complex if you want to look at it really closely. But like I said, we need to start from somewhere and then move on from there. But these are the dimensions that will be looked at. The safety things are there. So it's actually the dimensions that you saw in the red, gold, green type of, all the dimensions will be voted on. And every steering committee person would have the opportunity to vote and then give their justification and then, of course, their final recommendation as well, whether recommend unconditionally or conditionally or not recommend. Next one. Then it comes to communication. So the communication team will then kick in because, for instance, we've done for Beckett lymphoma. How many mothers and parents in Ghana are aware that this condition is now being catered for by insurance and the demand generation? This is a pure community level engagement and social engagement that should happen within the CSO front. Okay. Then next one is that when these things come out, and let's say a particular stakeholder is not has concerns about the decision, like I told you, this process will gather the approach to that decision. So it is supposed to be transparent as much as possible, such that you could appeal that, and you appeal on condition. I mean, clearly, we cannot accept that I just disagree with the recommendations and I don't have any reason, but I disagree. So you need to, the condition that can trigger appeal is that you have evidence that indicates that this particular evidence was not considered in the analysis, and if it was considered, could change the outcomes of the decision. That's a critical condition for an appeal. Okay. And you also need to do it fast. And in the process guideline, we'll share it when after the lunch, everybody will get a copy. We've detailed the time that you have to throw an appeal. Okay. Because we've engaged all stakeholders along the line. So all stakeholders have an eye on the process, and we know that you are following the process. So it won't be the case that this has been done and closed, and after 5 years, somebody comes and says, I disagree. I mean, you have to do your appeal in a stipulated time frame. Okay. If stakeholders think that the time frame is too short, there's a living document, we can always consult and update that. But for now, there's a limit on the time that you have to do an appeal, and there's also a criteria that will trigger an appeal. And then you throw it in, and it takes us back to the analysis. And the analysis will not be done by the same team that did the first analysis. We'll put that analysis on a different team, considering the new evidence that has come for to inform the analysis, and then it will be appraised and goes back through that process again. Next slide. Implementation. These recommendations are passed on to the appropriate implementing stakeholders. So the HTA governance structures does not take over any implementation functions from the statutory bodies that exist, meaning that the FDA will continue to do its work, the NHIA will continue to do its work. None of these functions are changing. All that is happening here is that recommendations have come, and if it is in the purview of the FDA to implement, if it's the purview of the NHIA to implement, they just pick it up and then they run with it, as has been the case for Beckett lymphoma at the time, through the able support that we had for Dr. Lydia Selby, who led that particular work within the insurance and also a strong collaborator for HTA. The implementation will be done, and the key points of interest for the Secretariat has to do with impact. So we need to be able to demonstrate that this particular HTA that has been done has impacted on the health system to this extent. It has, whether it has led to cost savings, whether it has led to coverage of other areas that previously was not covered, whether we have generated more qualities, whether we have, to what extent have we benefited the population? That is important. So that is impact assessment. Next one. There are some keynotes. In this process guideline, you wouldn't see the templates and the tools and the checklists and the forms that, for instance, the nomination, I said topic nomination, and there's a form that you will fill to submit a topic. You won't see that. But then we have soft copy admin notes that will follow this, so that all those templates and tools will be flexible in that soft copy that will be available online, and then that one helps us to tweak things as we go. When you do it in the hard copy, like it's a bit difficult. So that will be in the admin notes. It will be available online. Even this one, if the briefing I had is right, the soft copy of this is already uploaded on the Ministry of Health website for people to download. The next one has to do with that in all this process, you can be TWG members cannot be in both assessment and appraisal groups at the same time. Okay. And that we can co-opt any expertise that we need to join the TWG as needed. Next one. We need to develop an impact assessment framework, and like I've said, the notes and checklists are in the soft copy, the admin notes. I think we are next one. Okay. So I'll leave this on as I hand over for the next activities to take place. Thank you.
At this point, ladies and gentlemen, we have to now open the floor for maybe if there are questions, if there are comments, quickly we'll do that. The media has also drawn my attention that, of course, they'll need some sound bites. So if you are responding to issues, they want you to face the camera for them as well. So that Not for them, once they are here the whole day, they are only looking for one statement. Very important. So we have the opportunity now. If there are questions, if there are comments, so far, we can do that now.
I'm interested in the post-assessment. Let's say some medication or some tool, probably the aftermath of using it brought about some adverse effect. Who bears the responsibility, and what redress are given to the consumers who are the beneficiaries or the end users of these technologies?
For instance, when you look at the HTA decision matrix, I didn't see sustainability as a criteria. For instance, a technology, a product, a service may look to be the best option because of price and it meets all the other criteria. But how sustainable it is it, will that particular product be available for, let's say, 10, 15 years? Maybe for the next 5 years, it seems cheaper because maybe some program is supporting it. Is that why we are adopting it? And if it comes to a device, we know devices come in, but how available are the accessories and parts? So the issue of sustainability didn't come out quite clear. Thank you.
Of course, in such a forum, we don't have the time to tell you all that we are doing, but thanks for bringing this up. So with support from Pat, Bessie, thank you. She's been so supportive. We have engaged a consultant who is doing legal assessments. And the essence is that we want to look at the existing laws to see if there are any laws that we can ride upon, because as you know, it's very difficult to start something from scratch when it comes to enactment of laws. So that assessment has been done. We are finalizing the report and then we'll take it further. So we have taken some steps in that direction. In-house capacity for HTA, yes. We have about 3 people from NHIA who are parts of the TWG, okay. And as part of WHO support, as one of the presenters spoke about, WHO has supported us to, in fact, they are paying for 20 people to undertake health economics. And this is an effort to build capacity, to support. And Brian, how many of them are from NHIA? Yourself. Your question? I'll bulldoze your question. So listen, on a more, there are lots of agencies. I think, like Madame rightly said in her remarks, she said that we are looking at building capacity beyond even the ministry, okay? And the whole essence is that we want a workforce that has been trained to be able to support our national efforts. So a lot is being done in that direction. It doesn't hurt to ask if you are not too clear, so it's okay. I'll just pull in your legs. And then you asked about impact analysis. Again, we wouldn't have the time to go through everything, but it's also part of the strategy, okay? Somebody asked about sustainability. So yes, and my answer to that is that we didn't have time to take you through all the detailed steps. When we are doing an HTA, we consider cost effectiveness, and there are tools for doing that, okay? We consider even ethical issues. We consider availability, access. A whole lot of things are considered so that at the end of the day, we ensure that sustainability is assured, okay? Was there any other question that we have not answered? Yes, please. Go ahead. What was your question? Pardon me. There's a whole system that FDA, Seth, should I give you the mic? FDA coordinates to ensure that such issues are addressed, and this is called the pharmacovigilance system, okay? So whoever takes a drug, and let me use this to educate all of us, particularly the press, okay? Whoever takes the medication and the person reacts, there's a system, there's the MedSave app that you can access and then put in your complaint. You can also go to wherever you are given the medication to lodge your complaint, and it will be taken up. During the COVID, we really activated the system. So there's a serious or a robust national pharmacovigilance system that takes care of the issues that we've raised. And this is coordinated by the FDA. Okay? Are you okay with that? The look on your face doesn't. We can talk after that. I think we've taken a very long, so thank you very much. And you can have our numbers maybe after that, exactly. and then we'll be able to explain. Okay, you can have our emails even after this event. All your questions, we'll try and answer as much as possible. Thank you very much.
Today, actually, I was not in the mood to talk. I was reflecting over a lot of things as I go through the slides. But honestly, as a clinician and a public health expert, I've seen myself walking through all these exercises. And I've seen that we have a lot to share together in improving the quality of healthcare delivery to the generality of Ghanaians and even globally. From what I see, we will be practicing them. Whereas I'm sure majority of my colleagues might have also thought this is all about IT. But as we go, as a surgeon, technology and all these HTA processes actually reflect. And you could see our practices since I started 92 up to date. I can see HTA reflected in my practice and in my services as a even healthcare manager. So I think we have a lot to benefit from it, and we have a lot to contribute into this system. And not only clinical practice, even public health. We have a lot to come on board with it. I'm talking on behalf of all of them, that going forward, we would talk to each other and we'll participate more in this program, more aggressively, and we'll make sure that the desired outcome in healthcare delivery, which by WHO is a state of complete, not only physical, mental, and economic well-being of all the people. But because the pharmaceutical company and then the NHI funding is considered, we don't deal with so much money. So when it comes to a lot of issues regarding money, my people, the clinicians, are always antagonistic to the funding agency. But we believe in a couple of things. That is efficiency and then the outcome of any processes. And I believe that I can share that with you and share it with them going forward. Thank you very much for that.
I'm honored to invite the representative of the Honorable Minister for Health, Dr. Bafo Ehua, my boss and my uncle as well.
We are happy to be here this morning, now afternoon, for the launch of the Ghana Process Guideline for Health Technology Assessment. We congratulate all the Secretariat and all the team members for making this day possible for the launch of this very important document. Earlier speakers have defined health technology assessment, but the key theme is health technology assessment is a way to strengthen evidence-based selection and the rational use of health technologies, as well as increase efficiency when introducing and using these technologies in our healthcare system. The main purpose of conducting health technology assessment is to inform policy decision mechanisms. Decision-making within the policy process encompasses the application of organized knowledge and skills to guide cost-effective and appropriate choice of pharmaceutical products and medical devices to solve health problems and improve quality of life. Madam Chair, as a developing country, prioritization is critical for optimizing the deployment of limited resources. As such, the government of Ghana, acting through the Ministry of Health, has collaborated with relevant entities and stakeholders towards the application of HTA in the health sector. HTA development in Ghana has been a cumulative process with contribution from key partners playing major roles and offering various kinds and levels of support in the interest of Ghana. The development of HTA has gone through several phases from 2009 to date, with support from several development partners, including Bill and Melinda Gates, WHO, PATH, International Decision Support Initiative, Access and Delivery Partnership Project, and many others. The MOA, Ministry of Health, appreciates and thanks all the partners for their immense support. The Health Intervention and Technology Assessment Program in Thailand has also contributed to capacity building initiatives in Ghana. These covered areas such as fundamental concepts in HTA as well as HTA relevance in vaccinology. Ghana has also developed, through the support of our above-mentioned partner, the country strategy for HTA, and will soon launch the Ghana HTA reference key for setting standards for the conduct and reporting of HTA in Ghana. Ultimately, Ghana is well positioned for further collaboration and partnerships in moving the HTA agenda forward. The Ministry of Health has realized some initial successes from the development of HTA since its inception. There's this mention of hypertension model that was done through a WHO, and this also created space for work track on economic model. The model also informed the 7th edition of the Ghana Standard Treatment Guideline, that's the 7th edition. In addition, an HTA on Burkitt lymphoma was conducted to establish the clinical and economic impact of extending coverage of the pediatric cancers. We've heard it this morning. The Ministry of Health appreciates the tremendous efforts of HTA Steering Committee, the Technical Working Group, the Secretariat, and indeed all stakeholders involved in Ghana's HTA activities, be it directly or indirectly. We urge them all to continue to put in their best to support this very worthy cause. We would like to use this opportunity to thank all our in-country HTA partners, including the National Medicine Selection Committee, the National Health Insurance Authority, the Schools of Public Health of the University of Ghana, KNUST, UHAS, for their effective collaboration and contribution to Ghana's HTA processes and activities. We also want to thank all our development partners who have played various roles in the Ghana HTA story. Here among them are the United Nations Development Programme, PATH, Access and Delivery Partnership Project, Norwegian Institute of Public Health, Global Health Development Group, UK Institute for Health and Care Excellence, UK Department for International Development, the European Union, the World Health Organization for their continuous support for this process. Ladies and gentlemen, it should, however, be noted that the process for conducting HTA is just as important as outputs and successes of HTA and associated recommendations and decisions. The HTA process guidelines was therefore developed based on local context and evidence. The broad objective of this HTA process document is to guide the conduct of HTA in line with the principles of multi-stakeholder consultation and involvement, transparency, and the use of evidence in a deliberative process using HTA structure for Ghana. It is expected that all entities within the health sector shall commit to the outcomes of this process and work with relevant stakeholders towards implementation in a manner that maximizes health outcomes. So, finally, I want to invite members on the high table to join me to do the honest document. So, Madam Chair, Director for Master Services, the acting WR of Ghana, WHO, and my own Director of Master Ministry of Health. So, my honorable ministers, On this note, all dignitaries present, I hereby declare the process guideline for health technology assessment in Ghana duly launched.